Okay, do you guys hear me?
Yes, I can hear you.
Okay, great. I think we should be starting now.
Okay.
So, good evening, everyone. On behalf of the Endourology section of the Saudi Urological Association, I would like to welcome you all to this webinar. And I'm pleased to present our speakers for tonight, Dr. Mihir Desai, who is a professor of urology, and he is the chief for the Center for Robotics at the University of Southern California. And we have Dr. Renee Sotelo, who is the medical director of international health and a professor of urology at the University of Southern California. And our panelists for tonight, Dr. Hassan Al-Zahrani, who is a consultant urologist who specializes in MIS, and he is the Deputy Chief Medical Officer at the King Faisal Specialist Hospital and Research Center in Riyadh. And Dr. Raed Azhar, who is the President of the Saudi Urological Association, and he is a consultant urologist who specializes in robotics and MIS. And of course, me, Abdullah Al-Anizi, your host for tonight. So I don't want to waste much of your time. I think we should be starting now. We will kick off this webinar with the first presentation with Dr. Desai, who's going to speak about the robotics in upper tract urological conditions. Mihir, please.
Do you see my screen?
Yes.
So firstly, Abdullah, thank you so much for the kind introduction and the invitation to participate in this meeting. I hope everybody is staying well during this, very unusual times. In fact, my last visit or trip was pretty much to the Saudi Society meeting, and I can't believe that since then everything has come to a shutdown. But at least it's opened up new avenues for communication, and I hope that this kind of interactive educational collaboration, maybe not at the same rapid pace. Right now, there is a webinar literally every day, but certainly this could be a format that we should leverage and keep continuing at a more practical pace going forward. Also, it's a pleasure seeing the friends and colleagues in Saudi and Raid and Dr. Hassan. It's a pleasure being here. So as mentioned, today's talk is on basically robotics for benign conditions. We talk a lot about cancers in most of our meetings, but I think there is a lot of opportunity for reconstructive procedures being done robotically. And so I'll talk about a few of the basic upper tract ones, and I believe Dr. Sotelo will focus on the lower tract benign operations. So today, what I'd like to do is make this more of a video-based technique description of some of the common reconstructive procedure that one does. That includes pyeloplasty. I'll talk a little bit about ureteral reimplants and its little variations. Present a video on a robotic ileal ureter. I think an ileal interposition is a very a good operation that one can do robotically. I'll also talk about a robotic repair of ureteroenteric strictures. I think this is a difficult problem, and I do believe that the robotic platform gives an excellent opportunity of fixing a difficult thing post diversion. Most of these are for bladder cancers, but could also happen with diversions for benign issues. And just to finish off, if we'll do a little technique thing on robotic kidney transplants, which I think is a fairly I think technically straightforward, yet has a lot of potential. Pyeloplasty, as one knows, is the commonest reconstructive upper tract procedure one does in kids as well as adults, and this is what you would see in a typical patient with a UPJ obstruction. What I like to do is I like to do a dismembered pyeloplasty. We approach these mostly transperitoneally. You can also do this retroperitoneally in certain situations. I must caution though, if you have a very large pelvis and you anticipate that the UPJ is at a very lower level because it's going to have a very redundant flap, retroperitoneal laparoscopy, especially if you're using an excise system, is far more tricky when you go to the lower pole and beyond because of the angle of your instrument. If you're having an excise system, it doesn't matter much, but with the SI, it can be challenging. So we still do these transperitoneally. What I do is first of all, I don't disconnect the ureter at the UPJ right away. We actually would kind of make an oblique incision on the pelvis and leave this flap attached to the stricture segment of the ureter. I mean, here it's shown graphically long. Typically, these are not that long. It's a focal, almost a functional stenosis here. And so you want to leave this so that that also marks for you the ureter, because the flap would be attached on the side opposite to what you're going to spatulate. So leaving this attached allows you good orientation for spatulation. It also gives you a handle to move things around so that you're not touching the ureter itself. And then once you've done the anterior or posterior wall, as I'll show you, at that point, you can then disconnect this is the spatulation that you would do on the ureter. And then you can disconnect the stricture segment along with the flap once you've sutured one of the walls to the pelvic flap. So this point here is going to reach the edge of the spatulation there. Which also brings to point, and I'll make that point later. If you have a crossing vessel and if you think anatomically it makes sense pushing it behind, that's fine. But just remember, once you do your pyeloplasty in a dismembered technique, your new UPJ, because of the flap being here and your spatulation being here, is going to go all the way from there down to there. So your funnel-shaped pelvis will go like this to the ureter. And so the vessel, whether it's anterior or posterior, is actually going to be in relation to the pelvis and not really in relation to the UPJ. It is, I think, more a visual thing. When you're doing it transperitoneally, all anterior crossing vessels look obstructive. The same vessel, if you were doing it retroperitoneally, will not look obstructive. So you sometimes will have to, what you really have to do is dissect off the vessel completely so that once you've done the reconstruction, it moves up. It is not attached to the pelvis or the UPJ at this level. So you should do a good mobilization of the vessel. But once you do your pyeloplasty, it truly does not matter. But you just have to see how it lies. And sometimes it makes more sense to transpose. Sometimes it makes more sense to leave behind. But there is no hard and fast rule. The second part I wanted to mention about is so that part you excise. Now, the second part people say is, do you need to reduce the pelvis? And I think that's redundant. If it's a very, very large floppy pelvis, maybe you want to reduce slightly. And even if you do, what I do is I take once I've done this part of the anastomosis, I actually take a little diamond off the pelvis so that your anastomosis is already done, and then you just have to close this pelvis to itself. Now remember, when you have a very large pelvis and you reduce it excessively, sometimes the infundibuli in these large extrarenal pelvis can actually come extrarenally. And if you take too big suppose a diamond like this, you will notice that the incision can go very close to a infundibulum. And you may actually produce an infundibular stenosis when you try to repair. So the best part is when you've done your anastomosis already, you start opening this diamond from here, look inside, see where the infundibuli are. Make sure that there is no infundibulum that is ending close to your suture line before you do the pyeloplasty, before you do the dismemberment. But I would say I do reduction of the pelvis in less than 10% of all pyeloplasties. It's not usually a boggy pelvis that does not empty. In chronically dilated kidneys, it is the dilated calyces that don't empty, because some cases have predominantly dilated calyces and a smaller pelvis, and those of the kidneys will always have some problem with stagnation, stasis, stone formation, infections, even after you fixed the UPJ obstruction. And unfortunately, we don't have a good way of reducing calyceal capacity. You can only reduce pelvic capacity, but certainly you will find some very blown pelvises where you do need to reduce the pelvis a bit. So that's just a little view. And also remember, when you reduce the pelvis, leave the superior attachment of this reduction flap also attached. When you start suturing, disconnect it right at the end, because this thing can actually go right behind the vessels and you may not reach that very easily. It sometimes becomes cumbersome. So it's always good to have that to pull down so that you can take your stitch and make sure that you do a watertight closure. Now, this is a little video of a transperitoneal procedure. It's a right-sided case. As you can see here, I have used the retraction should be on the lower pole. And the first step is to dissect between the lower pole cortex here and the pelvis here. That is the key thing. So that you don't retract the ureter laterally like you do with a partial. And then once you retract that, you basically just mobilize the pelvis. I mobilize as little of the ureter as I need just for the anastomosis. But here, I'm mobilizing the pelvis here. That's a vessel there. It's a posterior crossing vessel, as you can see. And we'll see whether we need to transpose that. Now, typical teaching is anterior vessels need to be transposed posteriorly, but sometimes a posterior vessel can be a problem. But in this case, I start dismembering. I leave that diamond-shaped flap attached to the pelvis. I always pre-stent these patients. Number one, it allows me to do a retrograde pyelogram and rule out any surprising ureteral pathology. And I leave a small stent, a 4.6 centimeter French stent, so that there is enough space between the stent and the ureter to both spatulate as well as suture. So you can spatulate it nicely. And you want to spatulate not just through the stricture, but also such that once you repair, there should be no redundant ureter. Sometimes you have to do extra spatulation if your pelvic flap is longer, because the last thing you want is a loose redundant ureter staying right there that will come in the way that will actually cause a fixed blockage. So the pelvic flap here comes to the ureter. I use a 4-0 vicryl suture on an RB1 needle. And as you can see here, that flap that I left attached to the ureter is helpful in manipulating the ureter. And I've done very little dissection of the ureter, basically just enough to do the anastomosis. And so, and you can see here, my fourth arm is just retracting the lower pole up. The moment it retracts the lower pole up, the ureter and the pelvis are nicely suspended. Now, I actually do the anterior wall first. I feel that allows you to then rotate the ureter and see the posterior wall from the back. Doing the posterior wall from the inside theoretically looks good, but we've tried it both ways, and this actually works very well. So you take about just 2 or 3 sutures on the anterior wall. And again, I use a DeBakey in the left hand, which is a very delicate atraumatic instrument. And then now, once that is done, I dismember the flap and along with the stricture. And then for the posterior wall, you take a backhand stitch. You can retract that anterior suture up, and it shows you the ureter nicely. Thin, delicate bites. For all primary UPJs where the pelvis and the ureteral tissue quality is good, I do continuous suturing. But if I get something where there is a inflamed pelvis, for example, somebody with a long chronic stent or very bad infections or a redo case where the tissue quality is not very good, then I would do interrupted, just because I worry that if the suture, one of the stitches pulls through, I don't lose my entire suture line. It's not as much of vascularity. It is more that if you have an interrupted anastomosis, if one of them comes through, it's a small leak. But if you have a full suture line that comes through, then it starts leaking. I don't have any major objection to using braided sutures, but I have generally preferred using either monocryl or vicryl, just because I just worry that the braids in the sutures sometimes can cut through a thinner ureter. And so I've basically not used V-lock for any of these anastomoses. But if you are doing if there is a very large, thick pelvis and you're doing a very large reduction, the pelvic closure can easily be done by V-lock, because you can take big, thick bites there, and then you're not really worried about that cutting through. Now you can again start with the anterior wall. In this case, I think the pelvic opening and the ureteral opening fairly match. But if the pelvic opening is longer, then that requires a separate pelvis to pelvis suturing, which creates a Mercedes-Benz type anastomosis. You want to pull enough that it opposes it nicely, but not too much that it causes any ischemia or a purse string effect. And then that kind of, just going to go a little faster here, and that's the full anastomosis at the end. And then once that is done, you basically just tie it down. And I like to cover it with fat. So make sure that the amount of perinephric fat covers the anastomosis, and it also goes between the anastomosis. There's a little bit of pelvis left, as you can see here. We didn't have to do a pelvic reduction in this case. And we basically will suture that up. And as you can see here, once this lies down, the UPJ is going to fall down here, and this pelvis is going to, this vessel is going to be more in relation to the posterior wall of the pelvis than the ureter or the UPJ. So that is done.
One of the audience was asking here is, are you using a cutting needle or a round needle?
It's an RB1 needle, taper cut. So so the other thing is a little short video and a technique if you have concomitant stones. This is a patient with bilateral UPJs that has multiple stones. Stones can easily be removed. Stones in the pelvis is much more easier, and I'm just going to show you some techniques there. So one of the things is, if you have a small calyceal stone, then what you can do is you can make a small incision in the pelvis, enough that you can pass a scope inside, but not too big, so that you can actually distend the system with irrigating flow that doesn't leak. And you can actually do almost like a ureteroscopy or an endoscopy and basketing. But if the stones are you can make a small opening, but here it's in the pelvis, you can just open it and you can retrieve these stones and put it in a bag. And then you can also put a flexible cystoscope in to view any remaining calyceal stones. Make sure that you don't crush these too much. You can then inspect these calyces. Some of the calyces may not be suitable for inspection. Then what we've done is we've reduced this pelvic caliber, because in here we also had calyceal stones, and you can pass a scope in, and then you can look at the calyces and you can basket these. I would not spend too much time if you miss a small stone. You can always treat these stones later by a different method. Don't mess up your repair by excessive trauma and force of this. So that's just to show you the technique for a stone repair. So again, to summarize, I use a 4-0 Vicryl on a reverse cutting needle. For primary UPJs, it's a continuous suture. Secondary, it's interrupted. Vessel transposition is case by case. Routine pelvic reduction is not necessary. The one other point is, if you get a patient who's at a chronic long-standing stent for managing the UPJ, and you get to the pyeloplasty, say 4 or 5 months after, and it's got a long stent, that is the case where I would recommend converting the patient to a nephrostomy tube, but removing the stent. For most primary UPJs that have been stented, you may not even need a nephrostomy tube. You can just pull out the stent. The presence of a stent for multiple months will, at least for a while, likely keep that UPJ open. So patient probably will not have any symptoms, and the ureter can get back to baseline. So if you keep the ureter non-stented for about 4 weeks, the tissue quality when you're doing the repair is much nicer. And if at any point in that 4 weeks, the patient becomes symptomatic, instead of putting a stent in, make them prepared for a nephrostomy. This is very different when you're treating a stricture of the ureter. So for example, if you have a stone that has led to a stricture, or an injury that has led to a stricture, in those cases, the moment you take out the stent, they will become symptomatic right away, because it's a scar tissue. It is going to close off completely right away. There, you actually have to put a nephrostomy first. I take the ureter out. But the basic principle for strictures is you want to leave the ureter non-stented for at least 4 to 6 weeks, so that all the strictured segment declares itself. Because when you have a stent in, it might keep a partially scarred ureter open, so that when you're doing your UU or reimplant, you may actually think that that's good quality ureter, and that can give rise to a recurrence. So for secondary strictures, I always take out the stent for at least 4 to 6 weeks, drain them with a nephrostomy tube, so that number one, I can even assess the length of the stricture better, and the nephrostomy is a protection for post-operative care. And just a brief thing, this was a recent meta-analysis between robotic and laparoscopic pyeloplasty that found that robotic approach had shorter operative time, shorter hospital stay, lower complications, although the follow-up stricture rate was not significantly different in the long-term follow-up series. The robotics had a benefit on the funnel plot when this follow-up was shorter. But again, I feel if you have availability of a robot, you should use it. But otherwise, we did laparoscopic pyeloplasties for many cases. It's an excellent operation. Just takes a little used to suturing. Outcomes should not be different. One quick comment about secondary blockages. So you have to differentiate a secondary cause of UPJ obstruction, which is, say, for example, an impacted UPJ stone that causes stricture, from a failed primary UPJ repair. Those are two different entities. If you have a primary UPJ that has failed a pyeloplasty, the conventional teaching has been do an endopylotomy. This is a patient actually with a solitary kidney. He was a young guy, 25 years old, that came to me. He'd had multiple endopylotomies after that. They could always pass a stent in. They could always put a scope in. And so they couldn't figure out why he's having so many symptoms. And he was actually nephrostomy tube dependent because of the pain. And the moment the nephrostomy went in, his pain went away. Now, if you look at his imaging study, and if you focus on this area, the ureter goes here, the pelvis goes here. This part is patent, but this is not a dependent straight line repair. This is what I called a ureteral malalignment. A malalignment will not respond to an endopylotomy. In fact, what you will do is, by repeated strictures, repeated incisions and stentings, you will actually make the quality of this ureter even worse. So if you see something like this, forget doing an endopylotomy, go directly to a pyeloplasty. And this is the post-operative imaging. If you can see it here, it's a nice funnel-shaped direct anastomosis. This other kidney was actually only about a 20% congenitally small kidney, and it had complete drainage after Lasix. So these malalignments will always cause problems, and you just have to redo the anastomosis so that it is in a straight line, it is funnel-shaped, and that's the cardinal principle. So always image these before you automatically recommend endopylotomy. So again, pre and post, malalignment and the straight line. So that is what you want to see. Now, about ureteral reimplants, most of these are iatrogenic following gynecologic surgeries or endourological procedures or colorectal. You follow the ureter till it goes to the scar tissue. These are distal strictures. And then you just basically disconnect it there. For like this patient had a hysterectomy and injury. There's no need to go digging that fibrotic segment in that hysterectomy bed. And once you have the ureter disconnected, you drop the bladder down, and you want to stay close to the bladder wall and just mobilize enough that it reaches the ureter completely. For most gynecological strictures, the level of the stricture is very, very distal. So you don't really need to have to worry about too much mobilization. But I just want to show one point here. This is the bladder drop down. If this ureter were not that mobile, if the level of the stricture were higher, and if you wanted to fashion a Boari flap, what you want to do is make your incision horizontally at this level of the bladder. With one fourth arm, lift the apex of that incision up, and then basically just extend those limbs on either side wide. Don't go parallel. These should be almost like a diverging limbs, so that flap comes towards your bladder completely, towards the ureter. And so that's the principle of a Boari robotically. And you really have to make that horizontal incision very, very distal inside the bladder. But this was a fairly mobile ureter, so you basically spatulate it widely till you see a good supple bleeding ureter. One other thing that helps in these cases, if you have a nephrostomy tube and if you can't find the ureter well, you can inject ICG through the nephrostomy tube. So we always have that ready. I then pex the bladder first to the psoas belly or the side wall lateral to the artery, so that it's now in place. Because now when I make the opening in the bladder does not collapse on me. Otherwise, if the bladder is free, it will retract completely. So here you make the mucosal incision. Do not make any attempt to make an anti-reflux procedure unless you're doing a procedure for reflux, and especially in kids, you don't need to do any anti-reflux. And also make sure that you reimplant it at the superior lateral part of that bladder, so that when you do as high as possible, so that when you do a retrograde endoscopy, that ureteral opening is going to be right in your line, and you're going to be able to do ureteroscopy, put a stent in if you have to from below. If you reimplant the ureter all the way down into the anterior wall, it's going to be a very difficult retrograde access. Then you dunk a stent in, and then you basically finish the anastomosis. So that is fairly straightforward. Ileal ureter, this was a right-sided stricture. You basically can do it one of two ways. You can first do everything in the pelvis with the patient in lithotomy. So you mobilize the bladder, you identify a measured segment of ileum. Now, one modification I've done is I don't mobilize the ileum on both sides. I just mobilize one side, anastomose it to the bladder, then stretch it up, and then divide the ileum based on how much exact length I need. And also remember, you want to mobilize this bladder as much as you can so that you, again, almost like doing a psoas stitch, so you have the least length of the ileum. So the cardinal principle of an ileal interposition is have the shortest possible length. And remember, the ileum will stretch quite a bit. So err on the side of making it short, it is always going to stretch to where you want it to come. And this is the bladder part being done. And then we have moved it up, make a side opening on the ileum, and that's where the pelvis or the ureter goes into. And you can either do continuous or interrupted sutures depending on the width. And again, the principle is do not mobilize the ureter at all. And then you can actually thread a stent in there. And you can fix this ileum to the psoas, and whatever is the redundant portion, you can excise at the end. Another thing I always do in these cases is give ICG at this point, make sure that your entire ileum is nicely vascularized as well as the ureter. And an XI robot helps tremendously in this because you can do multi-quadrant surgery, but you have to reposition. So depending on the proximal anastomosis is all the way at the kidney, so the patient has to be in a modified flank, and that works out fairly well. Talking a little bit about ureteroenteric stricture repairs, traditionally the incidence has been approximately the 10 to 12% range. One of the things that we've used to prevent strictures is to give ICG. And so at the end of the cystectomy, end of the bowel isolation anastomosis, before reimplanting the ureters, we actually give ICG IV, that is through the iliac artery. It'll perfuse the bowel. You can check the bowel anastomosis, your harvested segment, as well as the ureters. And look here, this ureter has a reasonable amount that is not lighting up completely. Here it lights up to this spot. So this portion is questionable. This is completely and clearly vascularized. And then you also look at the other ureter, which is also vascularized all up to the end. Sometimes you can see a clear demarcation point, and this way you can confirm that you have no ischemia. I don't know if it's the same video or another one, but there was one video which showed a ischemic segment. So that's the ileum being perfused. There was an ileal conduit here in this case. So you can see that the conduit is nicely perfused. Then the bowel anastomosis is nicely perfused. And then you can check again the ureters. And you can see here on this side, the green is up to that point. This part of the ureter is completely not taken up. Now maybe, and while here, the green goes all the way up to the end. So now if I anastomose at this location, you could have ischemia. Now this could be something that opens up. It may be in spasm. But if I anastomose where it is clearly green, which you can do, and so I'm doing my spatulation in that location, this completely avoids that element of uncertainty of ischemia. So here is where ICG helps, and we've published this recently. And since we started this technique 18 months ago, our incidence of ischemic strictures is almost close to zero. And even management for repair of these, I again would recommend a direct reimplant as opposed to an endourological management, because basically it has inferior patency rates. It may increase the complexity and length of the stricture, and really has a greater impact on renal function. So this is one case where we had a left-sided distal stricture in the ureter. And when you go in robotically, you'll be surprised, especially if the cystectomy was robotic, that there are virtually no adhesions. And so here I was a little not sure where the ureter was on the left side. So we gave ICG through the nephrostomy tube, and you can now see where the ureter is going in. This is the left side. That's a sigmoid mesocolon there. So you can dissect out the ureter. That's the left ureter there. You can see green inside the ureter. And that's where we disconnected the ureter because we knew that this part is patent because it has green. The part beyond this does not have green. That's the segment of the stricture. So minimal mobilization. I did not even have to go lateral to the sigmoid. We were able to get it from the medial aspect of the sigmoid. And so you disconnect it because this is TCC. You want to make sure you excise that distal ureter and send it for pathology. And we actually got a nice opening in that same location of the ileum. We again gave IV ICG at this point, confirmed that the ileum was vascularized, that the ureteral wall was vascularized, and then did a interrupted anastomosis. You can see here, again, good vascularity on ICG, and do interrupted suturing, and halfway through the anastomosis, you can put a stent in there. And this is really a very, very quick, minimal mobilization, minimum morbidity. All these patients that we do go home the very next day. In fact, one patient went home the same day because, again, there's very little internal dissecting except for correct identification of the healthy proximal ureter, reimplanting it in there, and you put a stent in halfway through. And this patient actually had a neobladder as the diversion, and the neobladder is closed. And this repair is now complete. So that's basically the repair ending. You put another 2 or 3 sutures here, and this really works out fairly well. And I always leave the nephrostomy tube in for a few days more. Make sure that there is no leak before you take out the nephrostomy tube. That's my principle in any stricture procedure. If the patient has a preoperative nephrostomy, don't take it out till you're absolutely sure that there is no leak and everything is fine. The last thing you want is to take out a nephrostomy, the guy has a leak, and then you have to put it back in again. So that is that. And this was the post-operative nephrostogram that showed good drainage. And this is actually a patient with bilateral ureteroenteric strictures that we repaired. There was the left one actually was much higher at that level. The right end was light at the neobladder, but the patient had a fairly long chimney, as you can see here. And so we were able to do a bilateral robotic reimplant, and post-operatively, we could see that if you look at it, both the kidneys are not hydronephrotic, and you could actually see the drainage into the kidney. Now, last example on a robotic transplant, typical configuration like we do with a cystectomy, except we make a low phalansteal incision up front, don't open the peritoneum, basically prepare the external iliac vessels like you would. This is the vein, and then we used Gore-Tex sutures, and this is a venous anastomosis, posterior wall, that's the anterior wall, and then the arterial anastomosis. This was actually through the hypogastric. It was an end-to-end anastomosis that was made complete. The benefit of robotic transplant, in my opinion, is that you are doing the anastomosis so close to these vessels that people who are obese, who have a deep pelvis, left-sided grafts, bad vessels, actually is beneficial to do it robotically, because open surgically, you can struggle through that incision to go deep into the pelvis and do that anastomosis. Here with the magnification and just being right there, each bite can be taken securely. The only drawback is that even though we place this ice jacket next to the kidney, you might not have as good of hypothermia during the case as you have open surgically. But certainly the renal function outcomes in multiple series, including we've done now 25 cases with the team in India, has been excellent. So really, this is something to consider. It is an easy technical operation, of course, but a lot rides on it. But I do feel that vascular complications are likely to be lower. So in interest of time, and that's the ureter being reimplanted, I'm not going to show the video, but we'll be happy to take any questions now or at the end, whatever you guys want to do. But just giving you a little flavor of benign reconstructive laparoscopy of the upper tract.
Okay. Have you finished here?
Yes.
Okay. So I'd like to thank you for this very informative and excellent presentation. I think we're going to open the floor for discussion, or probably we'll hear the feedback from our panelists. I'm not sure whether Dr. Zahrani is with us or not, but let's start with, is he with us?
Yes, sir.
Dr. Zahrani, welcome.
Yes, sir. Thank you very much.
Okay, do you like to give us your feedback on Dr. Mihir's presentation?
Thank you very much, Dr. Desai. It was a very informative presentation. Just 2 or 3 points. Number one, with the pyeloplasty, I think, again, robotic to me is the gold standard. The problem with the PUG is the diagnosis, I think, when to do surgery, because sometimes we just find like hydronephrosis and the renal scan is not obstructed. And I mean, how do you figure it out? I mean, which patients you will operate on? Should you have both symptoms and obstruction renal scan, or should you do something different? Would you do a retrograde? So when go ahead.
Yeah. Yes, and again, pleasure seeing you, even though online. With UPJs, you will have a group of patients where it is clear cut. You know, a young adult presents with acute flank pain, you have a hydronephrotic kidney, no hydroureter, and if you were to do a renal scan, it'll show an obstructive pattern. That's the classic case, and there is no further workup required. Problem occurs in 2 scenarios. One scenario is somebody where you pick up an asymptomatic hydronephrosis just on routine imaging and have an equivocal renal scan. Now the question is this something that you should operate on, or is this something that you can monitor? And what I tend to rely on quite a bit in the renal scan is the differential renal function. So if the differential function is above 40% and stable, then you can absolutely monitor these, especially if these patients are older. So if they're in their 60s, 70s, if they've not become symptomatic over 60 years, what are the chances that they might stay that later on? Having said that, I have also seen a few patients who were asymptomatic then, and then they become 85, and now they become symptomatic, and now they are very sick to have anything, and they become stent or nephrostomy tube dependent. So it is a little bit of a catch situation, and given that lap pyeloplasty or robotic pyeloplasty is effective, if you clearly are convinced about the etiology and the UPJ, I would err on the side of operating, especially if the function is 40% to 30% range. If it is completely normal and they are asymptomatic, especially if they have comorbidities, just watch them. The second doubtful case is in the post-operative scenario. Post-surgery, now you're trying to evaluate their persistent symptoms. Are they obstructed or not? And that's a more difficult thing to assess. And I don't go on post-operatively on T-half at all. You have to look at symptoms and differential function. And if the differential function is stable, and if the symptoms are not classic, and if they do not go away with renal drainage, like putting a stent in or a nephrostomy in reliably, that's the difficult scenario where I would avoid doing multiple operations, because that's sometimes, you all know that pain can be of different etiologies. Maybe they had a primary UPJ, but their pain wasn't from the UPJ that has persisted. And if you keep trying to do procedures for the UPJ, you might be in trouble. And T-half is a little bit of it feels objective because it is a number, but it is subjective, has subjective places, depending on when the exact peaks are marked. You can actually change a T-half completely. And so I would just look at the curves, look at the imaging, look at the real-time dynamic things and assess. And sometimes you have to follow these up. One snapshot evaluation doesn't give you an answer. It is change over time that is relevant.
Excellent. There's a question on the screen regarding the minimum split function to intervene. And people answered 49% for 20%, 42% for 15%, and not only 9% for 10%. What do you think about that, Dr. Desai?
So I think you have to differentiate kids from adults and what their underlying GFR is. But I think most people would agree that less than 10%, it's probably futile doing a pyeloplasty. You're better off doing a nephrectomy. Or if they're asymptomatic, just let them be. But above 15%, I would say in a primary setting, I would still vote for a pyeloplasty. I think it's a straight enough operation that you can preserve that and do it with minimal morbidity. Anything that is secondary, if it is a failed repair, if it has other problems where you just want to be done with it and the patient is fed up with having stents and tubes and all for 2-3 years, then maybe 20% might be a upper limit. Anything above 20, if you can do a pyeloplasty, you should. Now, the thing again changes if, for example, it's a long segment stricture where you cannot do a primary anastomosis, and if you have to do an ileal ureter, then that percent becomes a little higher because that becomes a more complicated reconstructive procedure. And I don't want to do it for, say, a 22% functioning kidney, as long as the other kidney is healthy. So it also depends on how easy you feel or straightforward you feel that procedure is going to be.
Okay, I'd like to hear the comments of Dr. Raed Azhar, if you have any comments, Raed.
Yeah, thank you, Mihir, for this excellent presentation. I always learn a lot from you whenever I hear your presentation and your comments. So I have a question to you. So what do you think about the, like, for example, post-injury, like cesarean, post-cesarean section injury, post-rectal, surgery injury, ureters? When do you think is the optimal time to report those? When do you do like reimplantation or to intervene to repair these strictures?
So if you detect them, obviously during surgery, you want to do it right away. If you get an intraoperative consult saying, hey, I think I've injured the ureter, obviously it's there, you fix it. If you detect it post-operatively, my typical experience has been that most of these operations would have been complicated operations. That's why they got into the ureter, etc. And so a lot of times, and since you have an option of draining these kidneys with a nephrostomy or whichever method, you generally want to wait about 2-3 months for them to recover from that complicated procedure and then have more optimal things to repair and handle. I think if you go in too soon, you're going to go into a hostile area and create more problems. So I think either it's intraoperative or you wait a couple of months. There may be the anecdotal patient who's doing well. It was maybe a sharp injury that they missed. It was an otherwise uneventful case, and the patient is fairly good. And if it's within the first 2 or 3 days, you technically could make a case of going back in, but it usually doesn't present that way.
Yeah, and the other thing is, with these aerial interpositions. So, can you give us a comment about like doing right-sided versus left-sided interposition with regard to to prevent the rotation of the aerial part?
Yeah, so two things that I think are important. One is the right is obviously easier than the left because you don't have to worry about getting it underneath the sigmoid mesentery. But if you can keep that ileal segment to the shortest length, so what I do now is I really do a full mobilization of the bladder, even though I know I'm going to do an ileal ureter. I do a proper full psoas hitch so that I get the bladder up as high as I can. You do the bladder part first, but only disconnect one side of the bowel. So you disconnect the bowel, put the ileal ureter side to the bladder, then you stretch it up to the kidney as tight as you can and as short a length as you can. Fix that ileum to the psoas higher up near the pelvis where you're going to be anastomosing it. Then divide the bowel so that now you have 2 ends to do your ilio-ileal anastomosis. And then you anastomose it to the pelvis. And you'll actually see that you basically took not more than a 6-7 centimeter loop of ileum. That has very little redundancy. It has the least chances of any major complication, and they don't develop the UTIs and other issues that you get. The problem with an ileal ureter is if you get even 5-6 centimeters longer, then it keeps dilating with time. And then that's a vicious cycle. The left side, what I do is I make a nice wide window underneath the inferior mesenteric artery and the sigmoid colon. Sometimes you can even make a window above the IMA and get the ileal ureter into the pelvis from there. I also do that if I'm doing a reverse 7, where there are bilateral strictures and I'm using the same segment for both sides. Then you anastomose the left one first, you get it underneath the mesocolon above the IMA to the right side, anastomose it where you can then, and then stretch it down towards the bladder. So, but I think you have to, if you keep it under stretch and you keep it short, you'll be okay. And with ICG, I think giving that at the end to make sure that the entire segment is nicely vascular is important.
Beautiful, beautiful. There's a question from our colleague from Kuwait, Dr. Hussein Al-Enazi. He's asking you, in cases of chronically dilated calyces and impaired renal function, would you consider hitching the lower pool up to create a Y effect in order to enhance evacuation of the lower calyces?
You know, I have always felt that a dilated calyceal system is a problem. And if these patients start having repeated pyelonephritis and stones, etc., it's a very difficult problem to fix. And many of these may actually benefit eventually from a nephrectomy. I have just not had good success in any of the other maneuvers. I had one patient who's actually was getting repeated urinary infections each time requiring hospitalization following a pyeloplasty. And each time the UPJ was widely patent, we never found a problem there. But the moment we put a nephrostomy tube in, all his UTIs went away. And we eventually did a nephrectomy. It was a 21% functioning kidney to begin with. But I think these dilated calyces, megacalycosis type things are something, some patients don't get infected and they're fine. But if they do, then I don't think surgically you can fix them in most cases. They are better off with a nephrectomy.
I have a lot of questions actually from the audience, but unfortunately we cannot take all of them because of the time. And we kept Renee waiting all this time. Sorry for that, Renee. So I think I think we have to move to the next presentation, and probably if we have time at the end, we may take these questions.
Okay.
So next talk will be by Dr. Renee Sotelo, and he'll be speaking about robotics in lower tract urological conditions. Please, Renee.
Well, I'm gonna, again, thank you for the invitation. I'm gonna start talking about fistulas repair. I think that's more rare. Maybe you have not seen them. Can you see my screen?
Yes, clear.
Yes, we do.
Okay, perfectly. I'm gonna start talking about robotic repair of genitourinary fistulas. This is a very important entity that where failure is not an option. Many of these patients have previous repairs and they really struggle with their quality of life. And well, this is our complications robotic book in case you're interested to see more about fistulas. First is the vesico-vaginal fistulas. Most of them are done in our center through vaginal approach. We have 3 of my partners are trained by Dr. Ras, and they are very skilled doing vaginal approach. But instead of that, we do some cases, some of them they refer to me, previous radiation, failed through the vagina, or big tracts that require additional procedures. The first description of the laparoscopy approach for vesico-vaginal fistula was done by a GYN, Dr. Snesat, and basically he proposed to go and find a plane exactly between the bladder and the vagina, trying to go exactly in this plane. But many times we try, and after maybe 30 minutes, 1 hour working here, we open the bladder or we open the vagina. And then that's why we decide that we're gonna go and we're gonna open intentionally the bladder instead of trying to find this plane. And then we make a small cystotomy, and then we extend it through the fistula tract. And that's what we described it in 2005, the laparoscopy transvesical approach. And then also we did it in 2011. We did some cases that instead of intentionally open the bladder, we open intentionally the vagina. Cases with previous failed surgeries with too much scar here, we found that maybe it was easier to open the vagina get the robotic theory up, and then close the vagina, and maybe the incisions in the bladder was going to be smaller, and maybe the bladder symptoms or recovery was going to be fast. This was in 2005 when we described it, and then was also a AUA video award. And basically, you can see in the AUA library the technique. It's very simple. We just intentionally, as I mentioned, we make a small cystotomy, and then as we do, you can see here, for example, I have a sponge stick in the vagina, and I have a light of the cystoscope in the bladder. And then with the ultrasonic scissors, I open a very small incision in the bladder directly. I'm not trying to find the plane between the bladder and the vagina. I intentionally do a small cystotomy. We can put a suture to retract the upper edge of that incision to keep it open, as you see here. And you can put on two lateral sutures also if you want to retract and keep that line like a triangle. And then you'll see this is a Foley that was placed in the fistula tract. And now I'm extending the incision through the fistula all the way down. You see this, the gauze that's inside the vagina. Wow. And you see the size of the fistula. Now, there's some controversies if you should resect or not the edge of the fistula. I always try to do it a little bit to fresh stems. And now it's very important that you need to mobilize laterally, because you wanna non-tension in the repair. And you see, you have to be very careful how you're gonna extend it laterally in order to mobilize the bladder. And now you see, there was laparoscopy. I'm removing the edge of the fistula, and then very important, you find the plane between the bladder and the vagina, and you go as far as possible, because as you see here, with traction and contraction, I extend and looking for my plane, and because I want to go as far as possible to have no tension. Very important that you need to double check that you're not going in either way. You're going to have to go exactly in the plane. You don't want to make thinner your bladder. You don't want to make thinner the vagina, but more careful, you don't want to make thinner the bladder. And you see, you have a nice plane. And then after you have the plane, you do a transverse closure of the vagina. Then you anchor the omentum that you previously prepared. We do the omentum harvesting before putting the patient in Trendelenburg. And then we put a suture at the end of the omentum that will be easy to track and to find the omentum. And we check that reach the pelvis. And then after we close the vagina, we anchor the omentum. You see here the omentum is already anchored. And then you're gonna see the small incision in the bladder, and then we just close this cystotomy. When the robotic came, of course, now we have 3D, we have, and basically this is an example. You see when you put a double J stent in case the fistula is very close to any ureter, we always pass a wire through the fistula. And if you have many holes, you need to put many wires, or because you need to be 100% that you're gonna disconnect all the fistula tracts. Some patients have many fistulas because when they close the vagina cuff, sometimes that line of sutures include the bladder, and you see like a row of holes. I have seen 7 holes in a row. And in this case, you see I'm doing the small cystotomy. And when you get experience, you try to know exactly how far. You see in that case, I get exactly in the plane. That's the gauze that's in the vagina and extending up. And now that's the catheter that's delineating the fistula. And basically, again, I cut the catheter, you see, and then I create the plane between the bladder and the vagina. And now I'm just closing the vagina. You can do it with barber suture. And then there's the omentum that I already prepared. I'm anchoring the omentum. And then you see the size of the incision in the bladder is really tiny. And then now I'm closing the bladder. You can close the bladder, depend how big is the hole. You can do longitudinal if you don't want to be in the same line of repair. But basically, I do it in the way that I have less traction. If I feel that I can do vertical, if I have less traction, I will mobilize laterally. If I feel that it's easy to just come down, I will do longitudinal transverse repair. There are more complex vesicular fistulas. For example, this patient with ovarian cancer, she got radiotherapy, and she got 2-3 repairs fails of the fistulas, and she also have a fistula between the bladder and the vagina, and between the vagina and the rectum. That's the hole between the bladder and the vagina, and now I'm in the vagina, and you see the fistula tract from the vagina to the rectum, and from the vagina to the bladder. I'm now in the rectum through the vagina, and from the rectum, from the vagina also I go, and now you see that's the hole that's go. I'm going to inject methylene blue, and you're going to see that's the hole that's go to the bladder. And you see, these are more complex cases. Patient, she had ovarian cancer. They did a previous omentectomy. There's not omentum that we can use. And you're going to see, I think I show here that when I inject methylene blue to show that this one, you see, that one is the one from the vagina. The other one is going to the rectosigmoid. Again, you see all the catheters that you need to put, you put in the board. The blue or the green one is in the rectum, the yellow one is in the vagina, because you need to, when you open and you see a catheter, and sometimes these cases are, you need to identify perfectly. And if you need also to put the white ones are ureter catheters inside the ureters. Very important. We use the XI in these cases now, and you have 2 teams working. Getting all these catheters and all that inside the bladder, catheterizing the correct tract, sometimes take time. Now, in the meantime they're doing that, I'm getting access to, in order to save time, because of course, some of these patients have previous colostomies, if there was a rectovesical fistula, and then you have to have time also to release adhesion, get access on the abdomen. It's a good time to save time, is to start at the same time. This was the case that I was mentioning, also had that fistula. One of the ureter was included in the tract of the fistula. And then in this case, I went from the bladder, I disconnected to the fistula tract, I reimplant the right ureter. That was the ureter. I reimplant the right ureter, and that's the fistula. You see the green going to the rectum, the yellow going to the bladder, and then I dissect the vagina all the way down to remove all that tissue. I close the rectum, I close the vagina, I reimplant the ureter, and because I didn't have any other plane to interpose, I use the vagina that I resect as a second layer to repair the fistula. And that's where you see like that second layer of vaginal wall that I use as a second layer to close the fistula. Very important, if you have a fistula with uterus, it's rare. Usually the fistula that we see in US or maybe there is after hysterectomies, but also you can see fistulas that they have accidents, complications during deliveries, and sometimes during the C-sections, but the uterus is in. Very important here that you always need to go first and try to access the bladder directly. Don't try to find the fistula tract here. What happens if you try to find the fistula tract, you may go wrong and you can open the cervical canal. And you think that you find a tract and you think that this is the tract and you're open a cervical channel. Then you have to be very careful. The concept of intentional open the bladder is more important when you have a fistula with uterus. Now, let's talk about the other type of fistulas. First, the colovesical fistula. It's very simple. Usually it's in the dome of the bladder. Basically, you need to go with colorectal guys. You will separate the rectum from the sigmoid from the bladder, and usually you can resect the bladder and you can just close the bladder. Some people say that even you don't need it. You put a catheter and that hole in the bladder will close. I prefer to remove all that small area and close it. I feel that they will heal better. They will get rid of infection easier. But basically the important part is that they need to do a resection of the sigmoid. Now, the fistulas between the rectum and the bladder. It's very important that you need to understand first if this is after surgical complication. And the first question that you need to have in mind, if this patient, of course, males, if they have prostate or they don't have prostate. Why is this difference? It's because there's a fistula between the rectum and the bladder. And when the patient, I'm going to show you the difference. Rectovesicals with prostate, it means fistulas between the bladder and the rectum, but the patient has a prostate. Usually happen after rectal surgeries, or this is an example. They was doing the stapler line, doing a reverse of a Hartmann procedure. And when it was doing the reverse in the stapler line, they include the bladder and the ureter. And after that, the patient has a fistula in 3 ways. When you go to the sigmoid, and then you go all the way inside the bladder, and then you come back, and then you're in the sigmoid. And also the UO in the right side was included. The important here is because if the patient has prostate, it's very important that in order to repair this, you need to remove the prostate. I'm going to show you here the video. Basically, this is I'm inside now the bladder. That's the upper edge of the fistula. And you see here is the upper one. And then you're going to see down here is the lower one. And I inject methylene blue from the nephrostomy tube in the right side. And you see the methylene blue going here exactly out in the edge of the fistula because the UO in the right side was exactly in the edge of the fistula. And then basically in this case, I remove the prostate. I make a line here in order to have all this flap to close the rectum. And that flap helped me to close the rectum longitudinal. Of course, ideally, you need to close transverse the rectum, not longitudinal, but it's almost impossible. Everything's stuck. I put a chest tube in the rectum in order to see that I'm not closing it too narrow. And then I use ICG also to check that the perfusion of the rectum is okay. And then I do a plasty of the trigone like this. And then I do a new anastomosis. I bring the omentum, as you see here. Very important, you need to bring omentum to protect that repair in the rectum. And then you do the anastomosis and you do the reimplant. Very important, sometimes this fistula between the rectum and the bladder. The rectum has previous radiation. Sometimes the rectum is not healthy. Sometimes you just do what they call the turnbull. It means that you advance the rectum all the way out. And a few days after, maybe 5 days after you can just resect this necrotic area and then you attach to the anal margin the rectum. It means that you have a healthy rectum here, but it's again, you see, you close the bladder and you do a new anastomosis. And then rectovesical fistulas with prostate, you have to have in mind that you may need to remove the prostate. And this is the turnbull. You see it after, you see the rectum here, and then a few weeks after you go back and the colorectal guys do that and do the anastomosis. The rectovesical without prostate, very important. These are the patients after radical prostatectomy. They have been incorrect named as recto-urethralis because they're very close to the urethra. But these fistulas are not to the urethra. These fistulas are between the bladder neck and the rectum. These fistulas are rectovesical fistulas without prostate, because you can have a real recto-urethralis fistula after radical prostatectomy, where the fistula is between the urethra and the rectum. Very rare, because usually the fistulas are in the posterior racket of the bladder neck to the rectum. You see it here. This is the fistulas. In this case, what we did is that the same approach that we described for the vesicovaginal fistulas, then we intentionally open the bladder and we intentionally bivalve the trigon. This is the a patient, of course, if a patient is leaking urine, if the patient say that he's having stools in the fole, in the urine, pay attention. Again, we put a catheter. You see the catheter going in and out of the rectum. We delineate the fistula. Very important, will not go blind to find the hole. Of course, this patient will refer that they have pneumaturia. Very easy to confirm that this is a fistula without any doubt. But you want to know and you want to see the hole. Very important. This was a patient they sent me from Argentina. They told me, well, this patient is having some blood through the rectum and maybe hemorrhoids. I say, no way. If a patient is having blood in the rectum, you need to check that there's not a rectal injury. That's another reason why they can have blood. They can have, of course, pneumaturia, not immediately. They will have, additional to that, they will have cloudy urine, stools in the urine, in the fole, but they can have hematochexy because they can have blood in the stools and red and fresh. And I asked them to do a rectoscope and they see hemologs also in the rectum, big opening in the rectum wall with all that clots. Very important, of course, this is not obvious, that happened also. A patient after open prostatectomy, few weeks after, he was getting the catheter and the Foley through the rectum. Obviously, there was a big fistula. Usually these cases, because they're extraperitoneal approach, open, that's why they don't have abdominal symptoms, because they create the fistula through that. The patient that I show you with the blood in the rectum was this case. And it's very important because when they ask, I told, okay, if you go in and you put a catheter in the bladder and you're gonna try to see if the fistula heals, it's very important that you need to get that catheter under cystoscope and you need to put a wire in the bladder and you need to see that the catheter is going to the bladder. The catheter went all the way in. They took the patient first. They put a colostomy of the patient. That was the emergency. And then they want to put a catheter in the bladder to see if the fistula heals. But the catheter went in the rectum. You see it here. And the catheter is inflated in the rectum. And because they saw that the patient was getting urine through the catheter, of course, if the sigmoid, if the patient has a colostomy, the rectum works like a pouch. And it gets all the urine down there and it goes urine out. And it doesn't mean that it's in the bladder. But they thought because the catheter was getting urine that the catheter was in the bladder, and they leave for 6 weeks the catheter in the rectum. And of course, they have a beautiful fistula tract after that. Again, if you're gonna try to see if that's gonna heal, you need to put a cystoscope, you need to put a wire, and you need to guide the Foley with a console tip inside the bladder. This was the first cases that we repaired. We did it laparoscopically. Very important, this patient has always colostomies. The first cases they referred to us was patients that have a fail in the perineal approach or Kraski approach. Very important, if you have a rectal injury and you're gonna send colorectals and they're gonna do a colostomy, please ask them to do a ileostomy. You need to think that you're gonna need to go back in and you need to do it as lateral as possible because you're gonna need a space to go in. Sometimes they do the colostomy in the middle, and then you're gonna have very difficult to go back in. Basically, this is exactly what I'm mentioning. You need to go in the bladder and you bivalve the bladder, not, of course, a small incision, you bivalve the trigon all the way down. And the same thing we described for vaginal fistula. Then you separate the rectum from the bladder, and it's exactly how it came. We had a case and we say, why don't we do exactly what we did for basic renal fistula? Instead of the vagina, is the rectum, and we did exactly the same thing. We close the rectum, we bring the mentum, and then we close the bladder. The first cases, we did it laparoscopically when we describe the technique, and then we do it, of course, now robotically is easier, but also laparoscopy is feasible. You're gonna see here an example, patients that This is a fistula. You see here the cystoscopy. You see how thin is the bladder wall. I'm inside now the rectosigmoid, and you see the left UO, right UO, and you see how thin is the wall. Again, going from Douglas pouch first, I'm opening the bladder, and as soon as I open the bladder, there's a fistula. I found the plane between the rectum and the vagina. Here's a beautiful, I extend the incision here, and you see there's the anus here. And very important, the first stitch needs to go distally to the edge of the fistula. You need to be 100% that you're closing completely. Now we do it with a barb suture. We can do running. And then after you do the closure of the rectum, I'm closing here some of the suture of the bladder. Very important. I always bring the, you don't see here, I put the omentum. Let me show you here. Here's the omentum. And then I put a suprapubic tube. Very important, I try to keep the catheter in the urethra for as minimal as possible, but I keep the urethra and the suprapubic. Remember, the suprapubic tubes not always dry the fistula because there's some urine there that can still go through the fistula. If it's a difficult case, you need to keep the urethra catheter for 1 week. I don't like to keep it because that catheter is over the line of suture, but if you need it and you need to keep no urine in the bladder, you keep the catheter. There can be more complex cases where not only you have the fistula, you have also bladder neck contractures. If you have bladder neck contractures and if you don't repair the bladder neck contractor, the fistula will recur. And then in these cases, we do some of the approach from the Douglas pouch, but we also need to do, we need to access the rectus space, because you need to do again the anastomosis. And then in this case, you see the bladder neck is complete. You cannot get any wire from the penis. You need to go all the way from the suprapubic to put the wire all the way out. This is another patient that, not that one, that he has a bladder neck contracture, but it was not completely, but it was tied. You see how difficult was the catheter? I went all the way in to get some membranous or bulbar urethra, and basically, you know, this patient is going to be incontinent after, but I'm removing the stricture, and then I'm found in here. That's the fistula tract. The patient has 2 fistulas, and then I close the rectum. You see, I'm closing the rectum. Very important. I'm going to show here. I'm closing the rectum, and I open the Douglas pouch, as you saw when I start. And now I'm advancing from behind the bladder. You're going to see here how you see the omentum, how beautiful the omentum is all the way in now, advanced, and now I'm doing the new anastomosis. Now, the fistulas, well, of course, there's other cases where you cannot find the urethra. There's completely destroyed. One option is that you can go another team from below and they can bring the bulbar urethra up, but if it's completely destroyed and you cannot do it, one option is to put a permanent suprapubic tube. This is not a good idea. Sometimes the patient have discomfort with this. Sometimes you can use appendix and Mitrofanov outside, and basically the best option in these cases is the ileal conduit. But these are options that you have, but of course you need to close the rectum and bring the urethra. More complex cases, they do double colostomies and they have fistulas not only from the bladder to the rectum, also to the rectum to the skin. They try a cross-key approach. It failed, it did not close, and then they send me the patient. I told them I'm going to repair this first, and when I repair this, when the urine start coming out, when the urine stop here, this will heal. And that's exactly what happened. I repair this one with the technique I mentioned it, and then this second one close. And then I reverse the colostomy as you see here in the right picture. Now, the real recto-urethralis fistulas are fistulas between the prostatic urethra and the rectum. These are the fistulas usually after TURBs or after dilatation of the urethra, that they make a hole in the prostatic capsule and they go to the rectum. Patients that have bladder neck contracture and they try to dilatate them, they make a hole in the rectum, or after rectal surgery and they make a perforation in the prostatic capsule. patients that have previous radiotherapy to the rectum, and then they do surgery to the rectum, they do injuries in the rectum, in the capsule of the prostate. Or more common now, after all this focal therapy to the prostate, after cryo, after HIFU, after brachytherapy and external beam radiation, you have these kind of fistulas I'm going to show. These are the fistulas from the prostatic capsule to the rectum. This is exactly what I suggest that you need to do. Basically, you need to do, here's the fistula. It's very difficult to see the fistula in an open access because it's inside the prostatic capsule. You need to do a salvage prostatectomy, and you need to advance the omentum, and then you need to do a new anastomosis. This was the first case that I did. I did it extraperitoneal. I did it laparoscopically, and basically it's the ideal situation if you can do it extraperitoneal. And then you see my finger there. I'm removing the prostatic capsule, and I'm going to show you that's my finger in the rectum, the assistant finger, and then I'm suturing, I'm closing the hole, and then you do the anastomosis. This is an example, a patient after cryo. You see that's the hole. You're going to see the finger, also that's the rectoscope, and I'm going to show you in one moment. I also asked the assistant to get the finger. That's the finger in the rectum. And you see, usually the best, or the best, if you're going to have a fistula, the less damage is with cryo. And then this is the case. You need to do prostatectomy, you need to close the rectum, you need to advance the omentum, and you do a new anastomosis. It's only to give you an idea how difficult are these cases. Basically, you are, by the GPS, you have to go and find close to the bone. All the tissue is destroyed. That was the remnant of the apex. And basically, I'm just going, there's like a pseudo capsule. I'm just looking for the membranous urethra, and I'm resecting all that tissue. And now I'm closing in, you see that's the rectum. And after I close the rectum, of course, I bring the neurovascular bundles at the midline to a second layer. You see how nicely you advance the omentum from behind the bladder. And now I do the anastomosis. And very important, you have to wait a few months. I see this case, I already reversed the colostomy. Patient is doing great, but you need to follow and you need to check that the anastomosis is stable. There's no contractor, and then you send the patient for urinary sphincter. Other cases like this one, you see that they're more challenging. Obviously, you see after external radiotherapy, you see this is the pubic bone, all that tissue is necrotic. Sorry, all that tissue, you see all that tissue is necrotic here. I found the UOs. I put a stents to know where the UOs, and then I did my best, work few hours to find the urethra. And you see everything is destroyed. And this patient has chronic osteomyelitis because all that, you're gonna see how the symphysis of the pubic bone is completely destroyed. The cartilagus, you see it here in the midline. There was this pubic symphysis bone here. Everything destroyed, osteomyelitis, pus. They drained the patient openly. And of course, if you don't stop that fistula, all that pus is gonna continue. At some point, I found that it's what's going to be very difficult, even if I found of somebody bring me the membranous, the bulbar urethra, this is what's going to heal. All these tissues destroyed, and then I decided to do a ileal conduit. After all that, of course, it was very easy to complete the cystectomy, but you see, everything is destroyed. That's the pubic bone. You see how far is the bulbar urethra destroyed. And of course, for him, it's very important if we can repair the rectum, but you need to sometimes decide if you want to have both repaired. If it's the rectum, or he's going to have with only one ostomy, with orostomy, and then you can reverse the temporary colostomy. The rectourethral fistula after prostatectomy, the real ones, very rare, that they go from the bladder neck to the rectum. I only have seen one, and at this one, I approach this one through the perineum because we cannot approach this one below the muscle, the pelvic floor, robotically. There are some fistulas between the prostatic fossa and the pubic bone, like the one that I show you, but without fistula. No fistula to the rectum, but all the tissue destroyed and they make a fistula to the pubic bone. Patient had all these contractures, they try to dilatate the patient, and when they got the sounds, they make false roots, and those false roots create tracts, and they get a pubic infections. These are very difficult cases. Again, you need to go do a salvage prostatectomy. And then there's different options. Again, permanent suprapubic tube. You need to close the rectum, bring the omentum all the way down, close the bladder, a suprapubic tube, or sometimes this patient will not tolerate the suprapubic tubes. At the end, it's better to do ileostomy, but you repair the rectum and you explain them that the only option is to keep only one ostomy. The other fistulas are from the urethra to the perineum. After rectal surgery, you see you inject, and then you see it here. Usually this fistula will close if you have a longer period of a Foley catheter because they have a fistula tract, and those tracts usually heal even after radiation if you have a longer catheter. These are some of the numbers. I think that with that you have the basic idea that what we do for fistulas. How much time I have?
Unfortunately, we're running out of time. So
we're running out of time. Well, I think with that, you can have an idea. Basically, I think you have seen me here doing simple prostatectomies in Saudi. But in another opportunity, I can give you my perspective. I described the robotic simple prostatectomy 12 years ago. And it's interesting to see the evolution of the technique. And I think we can do that in another opportunity.
If you want to go, rapidly on a video, if you have a video to demonstrate the technique, and we can take questions after that.
Well, basically, let me find the concept was that when there was the first description in 2008, basically we was doing a transverse incision here at the bladder neck to do the enucleation of the adenoma, and basically that's what we did. The first description was Mirandolino from Brazil, and he was doing a longitudinal incision. He was doing some sutures in of the pedicles laterally, and basically when I described laparoscopy was a transverse incision. Then we did the same one robotically, and then with that incision in the bladder, not in the prostate, was not a milling. The incision was in the bladder neck, like a radical prostatectomy. And then I open the bladder, I see the prostate, and then we do the enucleation. We do the suture that we call the fishing maneuver. We put the sutures and we track the adenoma with the suture. Now we do it with the grasper, we have the tenaculum, and it's much nicer now robotically, but when we was doing that initially, we don't have that instrument. We put sutures to retract, and basically we do this maneuver, swiping and finding the plane. You see that we put those sutures there, and very important, we always bring the bladder trigone. We do the trigonization as open, and we bring the bladder mucosa to the prostatic fossa or to the posterior edge of the urethra. After that description, that was and then we close the bladder neck and the prostate. There are some examples of obese patients. I'm just going to skip that. Basically, this is a video to show that we're using the sutures. And again, you see the maneuver of swiping and finding the plane. I love to use the hook. You see, I'm peeling the capsule, the adenoma, and I found exactly the plane removing only the adenoma. Then, well, this was a big case. Now we use the tenaculum. As I mentioned, it's nicely, you see how you can retract, and you can change the tenaculum from right hand to the left hand, and you can retract and beautiful adjust your retraction as you need it. Some examples, 300 grams. The biggest I have got out is 420. And then after that, B. Patel make a modification of my initial description. And basically, he was doing what he called an intuitusception. He brought the bladder neck inside the prostatic capsule to do anastomosis. And of course, with this, you don't need irrigation. My only concern was that if you have any prostatic cancer, and if you have any prostatic regrowth tissue, you're going to be difficult to do any TURP because you're going to have the bladder neck inside the prostatic capsule. That's why I found that this was not correct. Now, BIP is doing what I'm doing now, is he's doing an intrafascial. Intrafascial, it means he's removing the whole prostate in order to do the anastomosis. And this is something that I have been doing now. I can make some comments. In 2013, basically, I described why not to do what Mihir calls a prophylactic prostatectomy. It's basically, I'm removing the prostate, but I'm really going intrafascial. I'm leaving the seminical vesicles. I'm leaving a nice prostatic apex, and not apex, prostatic urethra stump, and I do an anastomosis, but I remove the prostate. And basically I'm showing here that you see a nice urethra. I preserve the seminical vesicles, but I do all the intrafascial dissection. I'm suturing the seminical vesicles, and you see all the bundles are preserved. The Patel also, I think a few months ago, also, and some other guys are doing the same technique. And then at the end, I just do a lateral anterior reconstruction after the anastomosis. Why? This is a video you see is a real intrafascial, and I'm just going to show you how I advance. You see, now I'm going to do I think I'm closing in there the seminical vesicles, more for hemostasia than anything else. And then you see all the fascias are preserved. And now I'm doing the anastomosis, and then I'm closing I'm doing the anterolateral reconstruction. I close perfectly. And then usually this patient, I don't left drain, and the patient have a two-way catheter, no irrigation, like a radical prostatectomy. Why? When I describe it in 2013, I compare 79 patients with my milling technique and 75 intrafascial technique. I found that basically in the patient that I do intrafascial, the reason was because I was finding first that some patient was having cancer in the specimen, and that was some of the concern. And even with prostate biopsies, they was having cancer. And second, if the tissue grow back, of course, it happens when you follow this patient 5 years, 10 years, because you left the capsule. And also, that's why now also in USC, we're doing a prospective study, not randomized, but I'm comparing the new technique that I'm going to show that Monish described a few years ago. He's doing a posterior approach. He opened the bladder, transvesical approach to the adenoma. And I'm comparing now, I think we have like 80 cases that Dr. Gil has done, and I have like 80 cases also. And we found that in the cases that he did transvesical, like 14% of those cases had cancer. Even that 60% of those patients had previous negative prostate biopsy. And in the case that I did intrafascial, I found in 23%. In this case, in Venezuela, I found 22. Now in the US, I found 23, 24% of the cancer in those patients. Of course, if you do intrafascial technique, the the amount of tissue you remove is better, but of course there's a risk of erectile dysfunctions and incontinence. We found that basically in concern to the comparing the two techniques, the continence usually in 6 months was very similar. Even in the first months was better when you do milling than when you do intrafascial. But after 6 months and 12 months, there was no significance in the difference in the continence. But the patient have, of course, better long-term surgery and better results. Also, we checked the erections in patients with a shim more than 21, and basically at 6 months and 12 months there was not difference in the erections. As I mentioned, in 2014, Monish and his fellow Leslie described the transvesical approach. They open the bladder posteriorly in the posterior wall, and they do the suture to retract, and then they went through the adenoma. And also in 2008, me here, and we was doing single port adenomectomy through the umbilical. Me here came with the idea, why don't you put the port instead of the umbilical? Why don't you put the port inside the bladder and do a pneumovesicum? And then we did it. We did some cases in Venezuela and some cases in Cleveland. And also if you need it, you can open the port and get your finger in to help the enucleation. And this is a good example, patient with previous surgeries. And you see the incision, and that at the end, you can open the port, you remove the specimen, and you put a suprapubic port, and it's only a 2-centimeter incision. That's that was the first intent laparoscopically. Now the evolution, we did it also robotically. And now, that was in 2014 with the first studies of the SP. Now with the SP, I think this is something that's going to be revisited, getting the port inside the bladder and doing some surgeries through the bladder with the single port. Okay, it was a quick overview of single prostatectomy.
Excellent, excellent. Thank you so much, Rene, for this excellent presentation containing all these videos and challenging cases. The problem that we have is the time. We have many questions to have, but let's hear from our panelists. First of all, let's start with the Dr. Hassan Zahrani. Are you still with us?
Yes, Dr. Anazi. Thank you very much, Dr. Citillo, on this very nice, challenging cases. My question is, who should be doing these cases? I mean, should everybody be doing them, or should we limit them to a very, few urologists or reconstructive urologists?
Well, of course, fistulas are very challenging. I advise, basically in our fistulas, if there's primary repair, I don't think they can learn how to do it. But recurrent cases or rectoretrale fistula that have after radiotherapy or after failure repairs, I think it's better to refer to people who have done few of them.
What about the timing? Like if they follow rectal surgery in particular, so what is the optimal time to do these repairs?
Normally, I usually, if the patient has a colostomy and he comes usually with few months with a Foley, I tell them, remove the catheter, that fistula is not gonna close. After a few months, radiation, it's not gonna close, remove the catheter. It will reduce the inflammation of the bladder, use a diaper. All the urine is gonna go to the rectum, and from the rectum is gonna go out because he has a colostomy. And then I tell them, come. I explain them all the plan. First, I'm gonna find the urethra and I'm gonna do a neoanastomosis, and you have a temporary colostomy. Second, if I don't find the urethra, I'm gonna repair the rectum, and you're gonna have a temporary colostomy, and you're gonna have a iliac conduit. Third, if I cannot repair the rectum, everything is destroyed, I will ask colorectal to pull through the rectum, move the rectum out, and I will see if I can do a neoanastomosis. There are people have, and that's basically my plan. I explain them everything, and of course, I schedule the case from 3 hours to 8 hours. If we're gonna go for cystectomy or we're gonna go for only salvage prostatectomy.
Excellent.
we have a question for the audience, which is going on now. What is the minimum prostate size as an indication for robotic simple prostatectomy? So the minimum size, we put 80 and the maximum 120 to see what the audience will go with. I see that most of the audience are going with 100 grams prostate.
Yeah, basically, this is a technique that you need to do with big prostates. Of course, you will start to dominate the technique with smaller, but let me be clear that if you have 80 grams, 100 grams, and you are skilled to do it, laser enucleation, that's perfect. That's the most minimal invasive technique. Here now is doing aquablation. That's also a beautiful technique that, of course, they're working in the long-term results. There have been some modification also in aquablation. Mihir can comment about that. If they go back after they do the aquablation and they do some fulguration because there was some bleeding, that's an option. But I feel that for really big prostates, I feel that this is in my opinion, you do a beautiful enucleation. I like to do it intrafascial. I don't do any irrigation after the surgery, and the patient love it because they have a beautiful stream. They will not have any recurrence. They will not need any additional treatment. And I feel that, well, in our center, we have basically all these options. And now Mihir is one of the pioneers in aquablation. I have sent him some cases, and I think that's something that having all the tools in the armamentarium, it's an option.
Perfect. Let's hear from Raed. Raed, if you have any comments.
Yeah, thank you, Renee, for this excellent presentation. You made a very nasty condition. You explained it very elegantly. What I think is the most important thing about, especially things that are related to us, which is like post prostatectomy fistulas, is prevention. So basic understanding of the anatomy. Actually, usually when I do these cases, I'm very obsessive in terms of understanding the anatomy, trying, even after I finish the prostate, I always, we test the rectum, do a digital rectal examination. Sometimes I do a bulb syringe test, because these complications are very, the sequelae is very nasty. It's very, quality, it may affect like really the patient's quality of life. You may do like a very beautiful surgery, you get the cancer out, but you leave this patient with a very nasty process. Can you comment on some of the tips and tricks and types of suture that you use if you discover incidentally, like an injury to the rectum while you're doing the prostatectomy?
First, it's very important that the rectal injury can be done with your left hand and with your right hand. People always try to think that, or can be done by the suction with the assistant. You need to first understand who's the instrument that's making the injury. Sometimes you feel that it's the scissors or it's your right hand. I can show you how with the left hand, people like to do these maneuvers and they can open the rectum. The assistant contraction with the suction, he can open the rectum, or you can do it with the scissors. First. Second, the rectal injury can happen everywhere. It can be in the base, it can be in the bundles when you do non-preservation, or you can do in the apex. The rectum goes like a tent, and when you do the apex, you can open the rectum. And it's very important that you need to know that it can happen in all that locations in order to be aware that it's not only in the bundles where you always take care. Third, if you have any doubt, not all the rectal injuries are visible. Sometimes they're small, you cannot see them, do bubble test. Put some air in the rectum, you can put some irrigation in the pelvis, and you see there's bubble test. If bubble test is positive, it's better, because now you can repair the rectum, and 90% of the times, if you repair the rectum, there's not gonna be any fistula. If you repair the rectum and you recognize it, nothing's gonna happen. Don't get scared. it will be okay, but you need to recognize it. You repair the rectum and you do a bubble test after the repair to check that there's no leak. And then how you do the repair? Usually 2 layers. If the repair is going to be too close to the anastomotic line, you put a suture and you anchor it. You move the repair laterally. Try to avoid to be exactly in the anastomotic line. You need to do a better water tie anastomosis because you don't want any leak in the line of repair. If you feel that it's not perfectly repaired, you can open the Douglas pouch and you can advance the same momentum that we did for the fistulas. And you bring the momentum all the way down. You can bring the bundles to the midline as a second layer before the omentum. But very important, the repair. Fourth, when you're gonna remove the catheter, there's no rush. The most important thing is not the diet, soft toothner, antibiotics. No, it's doing a cystogram before removing the catheter. Because if you're in 14 days and you say, well, it's a small leak, but it's no fistula, it's not communicating to the rectum. But if you have leak, that leak is gonna erosion the repair in the rectum, is gonna be a fistula. There's no rush to remove a Foley after a rectal repair. Keep it for 1 month, do a cystogram, check there's no leak before removing the Foley. And if you have a fistula, usually are not that difficult to repair. And I'm telling you, now our colorectal guys, they prefer that we do it robotically with my technique, that doing Kraski or perineal approach. Kraski is gonna disappear. Opening the sacrum, going to the posterior rectum wall, finding the anterorectal of the wall, closing, opening the anal sphincter. You don't need all that. You can go robotically exactly to the fistula. But even that the fistula after rectal repair, after prostatectomy are rare, and it's going to be more rare robotically because you can have the perfectly angle with the robot to open the space. Now the fistulas after rectal cancer that they do radiotherapy before the surgery or after focal therapy, we're getting basically the fistula I'm receiving are after brachytherapy and external beam radiotherapy that they did it 5 years ago, and the patient had bladder contractions, they try to dilate them and they make a hole, or after cryo or after HIFU. And then that's the future of focal therapy. If people are in the learning curve or centers, and basically when they was doing whole gland ablation, now in our center, for example, we only do hemiablation. But I think that's something that can happen, and we're going to be receiving those complications.
Beautiful.
Thanks.
There's a question from the audience asking about the learning curve of laparoscopic physicovaginal fistula. And I'm adding to that, do you think there's any difference between laparoscopic and robotic physicovaginal fistula repair as a learning curve?
Well, I did many years laparoscopy. I was in Venezuela. We didn't have the robot for many years. I did more than 1,000 laparoscopy radical prostatectomies. So I had a good skill doing surgery and doing surgery. If fistulas are not that big, and you see that you straightforward open the bladder, you see the fistula. Important here is that you need to be sure that you're doing a good surgery, because you cannot afford to fail. And it's very important that you need to bring momentum. There's some evidence that if it's a primary repair that is not complex fistula, you don't need to bring momentum. Maybe, but I always do it. So I want to be 100%. These patients do not deserve another fail. And then it's very important that I be 100%. I don't use glue. I don't use peritoneum. I use omentum. And if you cannot get omentum, you can bring the rectums, a flap of the muscles, and you can bring the rectum down and you can interpose, or you can bring a gracilis up also robotically, and you can bring it up. But I feel that you need to put something. Also, basically the fistulas that I get are complex cases.
Beautiful. There's another question. I mean, people keep saying that robotically, the bigger the prostate, the easier the plane of the dissection. But I think the answer or the key is more complex than that. there are other things other than the size, anatomical pleomorphism, like for example, the presence or absence of the median lobe, the shape of the prostate, whether it's a lateral enlargement or superior inferior enlargement. All these make a difference during the dissection. So what do you think about that?
The big secret is that if the prostate is more than 100, 150, it's too big, don't think about it, piecemeal it. So bring one lobe and then the other lobe, or bring the medial lobe and then the 3 pieces. You want to see it big one. You want to bring it a unique piece. You can take one lobe and then go for the other one. And when you get one lobe, you have space to move the other one. And then always think that if it's too big, bring the medial lobe out and then go for the left and then go for the right. You don't need to bring everything in one piece.
Beautiful. We have a lot of questions, actually. We would like to spend more, but it's difficult, you know, to cover all things in this session. I would like to thank you, Dr. Sotelo, and I would like to thank Dr. Mihir, who has left us earlier because he has another commitment. I'd like to thank Dr. Hassan Zahrani and Dr. Raed Azhar for their valuable comments. I'd like also to thank our panelists, our audience, and I would like to apologize for missing any questions from the audience because of the time limitation. We have to conclude our session.
Can I say something, Dr. Abdullah? So I really would like to thank Dr. Adil Ammari.
Of course.
He is the cyber security behind this session. He really managed to get rid of all of these hacking attacks that I've been seeing in my screen. So thank you very much, Dr. Adil. You really did a great job.
Welcome. All the best.
Now he's joining.
That movie star is Almani.
Now I will call you to give you the setting that they.
If you don't know who's Almani, and he also get it in YouTube and all these technology that I'm really impressed.
Yes.
Right. Always a pleasure, my friend.
Thank you, Professor. Thank you very much.
Thank you so much.
Okay.
Thank you, everyone.
Okay. Enjoy your night and your breakfast.
Thank you very much.
Bye-bye.
Bye.
Dr. Abdullah.
Thank
you very much. It was an excellent opportunity to meet world experts. I will probably suggest in the future, again, just to come up like with a synopsis or a summary.
Hassan,
of
to the other room if you want.
Sorry.
Go ahead, Dr. Hassan.
And I was just going to suggest, on the WhatsApp group of the Saudi Urological Association, and after those webinars, if we can come up with this, the main points of the webinar, because this is what will be probably the audience remember, because again, it is a chance that people meet the experts and taking their experience. Like for example, a point because again of the time about